I'm going to be talking a bit on symptom burden today, and my only lament is that I don't have 4 hours to sit down and talk with you through all of the symptom burden. And this is something that I have a wonderful mentor in Dr. Mesa, and we've been looking at this now for over a decade, and him a little bit longer than me, although I won't say necessarily how long. Just a quick couple jokes to liven people up. So why does the nurse carry a red pen? In case she has to draw blood. And what did the MPN patient who found out that they have a large spleen say to their doctor when they came in the office? That the doctor had a lot of explaining to do. I know they're pretty bad. But, so I'm going to talk a little bit about what the experience of living with an MPN is. And this is a really, again, complicated, long topic, but it's something that I think at least we can cover kind of on the superficial level today. And if you have more questions, certainly happy to help you out afterwards. Feel free to email me, write down my email address that I have at the end of the presentation. We're going to talk about some of the specific mechanisms of the different symptoms that patients experience. And then we're going to talk a little bit about what some of our efforts are to try to impact symptom burden. Really from a clinical trial perspective, I did not have time to kind of go through some of our data that we've generated in terms of what patients themselves can try to do to impact symptoms. That's kind of a topic for another discussion. So what does it mean to live with an MPN? Well, you know what, I was kind of mulling this over too before really kind of putting together this presentation. One of the things that really is most prominent that I've experienced in my life, that it's not the greatest analogy, but I think it has a lot to do with what patients experience, which was recently moving. So I recently got married, and as part of that, both me and my husband wanted to move into a house together. And so he had his house, and then the complicated thing is I had my house, and we have this new house. So last weekend, we went to try to move his house, and it's kind of like the picture on the left. It's not a very big house. I mean, it's a beautiful house, but at the same time, it's not something that you think would take a long time to move. But in the process of moving, you find out a lot about someone, and it turns out that we are literally ready for the zombie apocalypse. He has got generators, he's got solar panels, you name it. And what I thought was just gonna be like hey, we've got a 20-foot truck, we've got a trailer, we're good to go. No, after 5 days of moving, we still haven't gotten everything from the house. But it's sort of like that with MPNs. You know, what we think of in terms of an MPN, I mean, I can sit up here and explain it all day, but your experience, what you go through on a day-to-day basis is gonna be so much more detailed, so much more intensive. And there are gonna be things that even in years and years of research, I still can't fully explain, or that we really don't have a great solution for. But that being said, I think that the experience of living and then the experience of sharing what you've lived through is critical, because the more we know about it and the more that you share that with other people that might be experiencing the same thing, the more in the long run we could probably do about it. So that's kind of my initial spiel. To kind of understand in general what this symptom burden is for patients with MPN, we kind of have to go back to what is really kind of going on. When we look at MPNs, the key characteristics are this idea that we have abnormal blood count production. And this happens because usually over a lifetime, although now more than ever, people like Angela Fleischman are looking at whether or not there's some genetics that might be there even when we're born. But from what we know over a lifetime, the cells that make our blood pick up little changes in the DNA of the cells. Then these changes can actually lead to the cells being produced more than other cells. And when that happens, over time, we can see that there's increased blood production. So when we look at essential thrombocythemia, we see more and more platelets being produced. For polycythemia vera, we see more and more red cells being produced. And then in early stages of myelofibrosis, we can have a high white count, sometimes still high platelets and red count, But over time, years and years of trying to produce all this blood ends up burning out the bone marrow and scarring it. Similar to if you had a cut, if you cut it in the same place every day, that would start to scar over time. And that scarring makes it that the cells don't grow as well, so we start to see very low blood counts as myelofibrosis tends to progress, and sometimes we can see increasing of the spleen size, and we worry about blood clots, bleeding. But what's really key too is that when we look on a large scale, what happens to symptoms over time? We can see that when someone first really kind of picks up these changes in the DNA and starts to overproduce blood, we start to see the symptom burden creep up. And this is really going to be a lot of factors that play into this. We can have baseline health status, this underlying inflammation, and that's basically the stress caused by the cells that are being basically producing abnormally. We also can see blood clots, especially for some folks, that's how they're initially diagnosed. We'll have a blood clot either in the abdomen or maybe in one of the veins of the leg or sometimes even in the lungs. Our initial treatment efforts are to try to reduce down the blood counts, especially for essential thrombocythemia and polycythemia vera. And a lot of times initially we'll see symptoms get better. For patients with polycythemia vera, the classic scenario is when I give someone their first phlebotomy, they usually come to me the next visit, they're like, I feel so much better. And I'm like, yes. But we also know that some of those treatments themselves can actually be related back to symptom burden. So especially when I do phlebotomies, I'm taking out iron. And over time, it takes a while. For some folks, it takes around a year. Where I'm taking out the iron, you can actually get symptomatic iron deficiency. So things like fatigue, you can have some problems with concentration, memory issues. You can also get some restless legs symptoms at night. You can start craving weird foods, things like chewing on ice. We also know that people can sometimes still develop blood clots despite our best efforts to try to reduce the risk of blood clotting. And we also have other side effects of medications. Things like hydroxyurea can cause mouth sores and ulcers, skin issues, superficial skin cancers. And when we start to see these different effects, once again, make symptom burden creep back up. And over a lifetime, we start to see, again, different factors that might impact blood or symptom burden either better or worse. We can start to see, in some folks, evidence of disease progression. Sometimes they don't do as well over time, especially if they have other medical issues going on. And then over time, you can start to get some depression and other things that might be playing in. Unfortunately, I don't want to make it sound totally dismal, because some patients do great. We impact the symptom burden and they feel wonderful. And then some people, we try to take the edge off and we don't always do a good job. So let's go through what are some of the specific symptoms that patients can experience. The number one most common and most severe symptom is fatigue. So in this graph, you'll kind of see I'm going to be going from the most common symptoms to some of the least common symptoms that we see that we can kind of attribute to the disease. And then how big the symptom is how severe it is, kind of relatively speaking. So on a scale of 0 to 10, the bigger the balloon, the more severe the symptom. The second most common symptom is problems sleeping. So around 65% of MPN patients will complain of this. For fatigue, it's over 90% of MPN patients. There's been a little bit of variability, some studies upwards of 80-ish%, but most studies will show more than 90%. We look at sad mood, the next most frequent symptom. 62% of MPN patients experience this. Concentration difficulties. So this can be anything from memory problems to just really feeling like they're in a fog. That's kind of a more common description that I hear. But 61% of MPN patients will experience this. And it's a little bit more in terms of severity. Problems where they feel full very fast, 61% of patients. And again, this can be relatively severe in some patients. problems with inactivity. So this can be everything from just not moving as much, not feeling like they can move as much, to just really not having the will or energy. Sexual problems, 57%. Although this is not the most prevalent symptom or most common symptom, it is pretty severe. When patients have it, this is something that can really impact not only their life, but the lives of their loved ones. Night sweats, around 56% of patients. And some folks, and we call them night sweats, but in some folks, we were talking even this morning, some people will have severe day sweats as well. Dizziness, sometimes described as vertigo or just feeling really lightheaded, having problems keeping balance, 55%. Abdominal discomfort, to speak a little bit to that, we'll talk a little bit later on, there's multiple things that can cause that, things from a large spleen to blood clots in the abdomen. Sometimes there can be issues with constipation, there can be issues with even just having what we call microvascular problems in the gut. Bone pain, 48% of patients complain of bone pain. Headaches as well, 48%. Specific abdominal pain, and we tease this out because not every patient will have abdominal so discomfort's a little different than pain. I have a fair amount of patients that will say, well, it's not pain. It's just, I feel uncomfortable, I feel bloated, it just doesn't feel right in my abdomen. So, but some folks will have specific pain. Cough in 46% of patients, and I have a lot of theories on cough specifically, although we kind of think of it as maybe being something due to maybe a little bit of sluggish blood in the blood vessels, and some people can even have blood clots in the lungs. I honestly have found a lot of patients will have, with a large spleen, will have cough that's worse at night. And then I see a fair amount of those patients actually get better when I start to treat acid reflux. Because if they have a large spleen, when they lay down, pushes right on the stomach, and the stomach acid starts to flare up into their throat and cause a cough, kind of a reflex. Weight loss in 34%, and then fevers in around 20%. What we know about these symptoms, they are significantly worse than people who don't have MPNs. Some of our colleagues in the UK worked with us to do the Mosaic study, where we compared an assessment tool that we had developed, symptom burden in patients who are normal, healthy controls to patients with MPNs, and we saw that it was significantly worse in patients with MPNs. But what's super cool is that the MPN experience, you can be around the globe and we see patients that experience very similar symptoms. Now, that doesn't necessarily mean that you're going to have the same symptoms as the person next to you, but when we take everyone's data and include it together, we see that these are common themes, and they're similar in terms of prevalence and severity to other people with MPNs across the globe. When we've done some special analysis of our data over the years, and one of the things that we looked at that were relevant to this conference, specifically what the difference is in symptom burden between males and females. And we see that for women, specifically, fatigue gets worse. They tend to feel full more fast and can have that abdominal pain and discomfort. Women have higher issues with headaches, problems with concentration, dizziness. They have more numbness and tingling, more sleeping problems, a more sad mood, night sweats, and bone pain. We do see, though, despite those worsened symptoms, overall quality of life, things like weight loss, fever, itching, cough, inactivity, and some sexual difficulties looked similar between men and women. So how exactly can we figure out what's going on in terms of symptoms? So some of the things, when I hear of a symptom in a patient, I'm starting to think about that I know that could be related to that symptom, as I start to think about blood clots. So especially if they're having new or suddenly worsened abdominal pain, or for some patients, even chronic abdominal pain, I start to think of, did they have a blood clot in their abdomen? Do we need to worry about blood clots in the lungs, again in the legs? For some folks, one of the more interesting cases, I had a patient with ET over the years that you could actually feel little bumps under their skin that when their platelets went higher, you could literally feel the bumps get bigger. And then when the platelets went lower, the bumps seemed to go away. It was the most interesting thing. We ended up trying to take out some of their platelets. She had very, very high platelets. It was a unique mechanism called plasmapheresis, where we actually took out the platelets and her bumps got better. We can see low or even high blood counts impact symptoms. When the blood counts get too high, the blood can get a little bit sluggish. And when the blood counts go too low, you can start to feel very fatigued, or that there's not enough blood to go around and provide oxygen to the different tissues, and especially to the muscles. Disease progression can sometimes worsen symptom burden, especially when we see people go from ET, PV to MF, or in the worst case scenario, from MF to acute leukemia. Different types of organ dysfunction can cause fatigue. So especially if you have a large spleen or sometimes even large liver, sometimes we can get the lungs functioning abnormally if we get blood production in the lungs. So there's lots of different things there. And then disease-related symptoms themselves. So things that I would say are more kind of constitutional symptoms. So fatigue, night sweats, weight loss, fevers, chills. And then you've got to think all of these things can happen on top of someone who might already have medical issues going on, that might already be on medications for other things that might impact fatigue, and I'll talk a little bit about this. Inflammation is kind of a key aspect of the disease that we've been interested in that can basically contribute to the symptoms, often in ways that are not typical of other diseases. So specifically, when we look at inflammation, it can cause a lot of those constitutional symptoms. We can see inflammation contribute to nutritional deficiencies for MPN patients, where they just don't absorb things as well. They can get very low cholesterol levels in some folks. We can see inflammation contribute to lower blood counts by basically suppressing the production of blood. You can see inflammation cause issues with blood clots, and then ultimately that organ dysfunction. So a lot of our research these days is kind of looking at the role of inflammation in these settings, but this is certainly just one of the contributors. So I want to focus on some most common specific symptoms. So fatigue. So when I talk about fatigue specifically, there's a lot of different words that you can use to describe fatigue. So in the dictionary definition is extreme tiredness, typically resulting from mental or physical exertion or illness. But that being said, some patients say they just can't get out of bed in the morning, that in the afternoon they just can't stay awake, that they feel just worn out. And I do try to tease out when I see someone with fatigue whether or not it's different from shortness of breath, where they feel excessively sleepy. That could be something completely different. Or whether or not they have that lightheaded or dizziness. Because if I'm hearing those things, I'm thinking a little bit different than I think just from that fatigue or weariness alone. We did, a couple years ago now, a 70-item international survey of MPN patients that specifically focused on fatigue. We saw that fatigue was quite severe in a lot of patients, and that it really impacted their lives, everything from their aspirations to travel plans to long-term planning, vacation planning, and it limited, for the majority of patients, their normal daily activities. Again, to kind of just cover with fatigue, what are some of the different pathways that can cause specifically fatigue? So high or low blood counts. We now know more than ever, and Dr. Mesa has recently published on this, that the cortisol or stress production in MPN patients is different than normal healthy people. And this can, over time, cause fatigue. I won't get too much into the mechanisms, but that's really kind of a key finding. We know, of course, sleep disturbance can cause fatigue during the day. Depressed mood can play into fatigue. If you just don't feel like there's much point in getting up, you're not going to really want to get up. And sometimes people can feel very, very tired from just even the mental exhaustion of having an MPN. And then finally, that inflammation pathways. We know, again, that there's many other issues that can contribute to fatigue. In this large survey, we saw that there were a fair amount of patients who had other underlying health issues that may also be contributing. So everything from heart issues to lung issues to kidney problems that can make you have a little bit too much fluid on board, to different endocrine issues like low thyroid function. We also saw that there were a lot of different medications that patients might be on. A key one is steroids. Steroids might give you a pep initially, but over time they can actually make you feel fatigued. Even blood pressure medications, if your blood pressure especially is going on the low side, you can feel more fatigued. Anti-anxiety medications, as much as they can help, they can actually worsen fatigue. Cough or cold medications can impact fatigue, antihistamines, the list goes on. And we looked specifically at mood, and this was one of the first studies to look at mood, and we saw that 23% of MPN patients in a screening tool were at high risk of depression. So this is something, especially if you're feeling like sometimes you just don't even want to get out of bed in the morning. The question is it the chicken or the egg? And a lot of times I think that it's a result of the MPN itself, but this might also mean that there's things we can do to try to pep up your mood that might also help improve the fatigue. Another symptom I just wanted to cover briefly was abdominal symptoms. So again, this can be multiple different things: that abdominal pain, abdominal discomfort, feeling full very fast, and there's a number of different things that can be related back to. Certainly a large spleen is one of the major reasons I see for abdominal pain, but you can get those abdominal blood clots, you can get risk of increased pressure in the abdomen, you can get bloating, and then you actually can get potentially some increased nerve stimulation, things that make your nerves more on edge. In terms of those constitutional symptoms, we call them, so fevers, chills, night sweats, weight loss, these a lot of times are directly mediated by that inflammation. Although sometimes, especially for weight loss, we can see a number of different factors playing in. We can see things like, again, that increased pressure in the abdomen, causing us to not digest our foods or feel so full that sometimes we just don't even want to eat very much. That inflammation itself can actually, again, cause our body to need more nutrients than before. So even though we're eating the same amount, we're using up those nutrients so fast that we actually start losing weight. Microbiome changes, and this is something that Dr. Fleischman's looked at, and we are interested in looking at as well. And then, of course, that appetite issues, getting full very fast, and that spleen can play into the weight loss. There's also this category that we like to call microvascular symptoms, so things like itching, some of the cognitive issues like headaches, dizziness, memory changes, and then sexual dysfunction. There's a number of different things. One of them could be the cells functioning abnormally. When we produce too many cells that have a lot of inflammation within the cell, again, that inflammation from those cells reacting when they shouldn't can actually, that's what's thought to mediate a lot of the itching with MPNs. Iron deficiency can also play into that. We see some, especially for depression, with this inflammation, we can actually see the barrier between the brain and the blood start to break down a little bit, and the inflammation cross into the brain. And this has been studied in other disease states. It is hard to study because getting biopsies for that is very difficult, but it is thought that some of the inflammation can actually mediate that. Of course, depression, blood clots can also be a part of this. Ultimately, in living with an MPN, these things can cause hardships. We see a high rate of emotional hardships, financial hardships, physical hardships, and then ultimately interfering with daily activities. And so this was actually a lower percentage than we had seen in the other study, but still something that is, depending on the patient, can be very prevalent. And one key thing is that, around 60% of patients said that they felt worse than their physician was aware of. So this is a good plug to talk to your physician about these issues that you're dealing with. And ultimately, these can impact even our financial ability by impacting our work. So lots of MPN patients had employment change due to their MPN. They left a job, went on medical disability, had reduction in work hours. Some took early retirement, changed from a full to a part-time job, or took another job with a lower salary just to try to deal with these issues. I won't get into this too much, but in getting into what we're trying to do to impact these things, we've been looking at different vitamin deficiencies and nutrition, and I'll talk about that in a second, but certainly diet is critical, I think, in maintaining our body's ability to deal with things. And we've seen initially early signals that exercise may, at least seems to have a relationship with overall fatigue, where people who exercise more had lower fatigue. And so that led to the yoga study in MPNs, and I won't go into these too much, but essentially we had two different investigation efforts. One was a 12-week online yoga course, and then we'll be talking about this a little bit in a couple minutes here. And then subsequent to that, we had another yoga course where we were able to have people, where we had a control arm where they waited a bit before they got the intervention. But overall, we did see an early signal that there might be some improvement in inflammation, but overall, patients also felt better with the yoga. We have two different early stage cognitive interventions, or basically things to try to help with that mindfulness, meditation, mood. One's called the Calm study, and it's looking at the Calm app. And another one's called My Act, which is acceptance and commitment therapy. And these are to basically help, again, with that mindfulness, being in the moment. And in other disease states have been found to help with, sometimes with inflammation, but especially just with being able to cope with what's going on. Near and dear to my heart, Angela Fleischman's heart, is this idea of nutrition in MPNs, and there's two ongoing efforts. One we're getting up and running in San Antonio, and then one that Angela's been working with at UC Irvine. We've looked at both the Mediterranean diet, and then I have up and running a nutritional ketosis intervention, looking to see how this might not only alter how patients feel, but ultimately potentially alter blood counts, and really kind of looking at that in the very early stages. We have another one that we've been looking at in terms of N-acetylcysteine that me and Angela are talking about moving forward in the near future, because we had some early signals that N-acetylcysteine might be associated with lower symptom burden. So in all, I'd like to thank you all. Hopefully I didn't go too far over time.